So today we'll discuss everyone's favorite, the BCG vaccine. So let's directly dive into the basics of the vaccine. So the first most important thing to remember is that it's a live vaccine, so we need to be more cautious, especially when using it with the immunocompromised kids. It has to be given at birth. The dose is 0.05 ml in those less than 1 month of age and 0.1 ml for those older than a month. It is always given intradermal, the side being just above the insertion of the deltoid on the left arm. That has been decided as a convention and it has to be given on the left arm. The strain that's used to prepare the vaccine is the Danish 1331 strain. Now, if you look at the picture, it's the BCG vaccine comes as a freeze-dried preparation, so it's more like a powdered form, and it has to be reconstituted with normal saline. Once it is reconstituted, it has to be stored between 2 to 8 degrees Celsius and has to be used within 4 to 6 hours of reconstitution. If by chance there is some amount of vaccine left even beyond that time period, then it has to be discarded. You cannot use it. It is not safe. Okay, so this is about the basics of the BCG vaccine. Now, next important concept is catch-up immunization. So what do you understand by the term catch-up? So basically, if a vaccine was not given at the time it was supposed to be given, up to what age can that vaccine be safely given is what is the definition of catch-up. So let's say BCG ideally is supposed to be given at birth, but for whatsoever reason the vaccine was not given, then you can give BCG up to a year according to the National Immunization Schedule and up to 5 years according to IAP. Now, where do these numbers come from? We all know that India is endemic for tuberculosis. So it's assumed by this period of time, the child has been exposed to tuberculosis and there is no need to give a BCG because that exposure has already happened. So that's where this number 1 and 5 comes from. So again, important to remember, often asked in your exams, is catch-up immunization according to IAP for BCG is 5 years and according to NIS is 1 year. Now next, what is the normal reaction that you see after getting a BCG vaccine? So immediately there should be like a 5 mm wheal. After 2 to 3 weeks, it gets converted into a papule of 4 to 8 millimeters. By about 5 weeks, the papule breaks and forms like a shallow ulcer. And by about 6 to 12 weeks, it leads to healing, causing fibrosis and a permanent scar of about 4 to 8 millimeters in diameter. So that is a scar that all of us ideally should have on our left arm. And this is how the normal reaction to a vaccine progresses. Now, next very important clinical question is, what do you do if there is no scar? Does that mean that the child did not receive the vaccine? Do you have to revaccinate? What is it? So what do you do if you see no scar on the left arm? So if there is documented evidence of having received the BCG vaccine, let's say the mother gets an immunization card where the BCG vaccine has been ticked, that means the child has received it. In that scenario, there is no need of revaccination. There's nothing else that you need to do. On the other hand, if there is no evidence of immunization, like either there is no record or the mother isn't sure whether the child even received the vaccine or not, and the child is older than 6 months, then in that scenario, you can revaccinate the child. Again, there are a different school of thoughts for this, whether you want to or you should not. But in the second scenario where there is no documentation and the child is more than 6 months of age, you can revaccinate. So these are the two scenarios that you can think of if you cannot see a scar on the left arm. And if you have to clinically correlate this, a lot of our case presentations in examination and general examination, we look for the BCG scar. So whether it's nephrotics, whether it's SAM, whether it is CNS infections, maybe meningitis, encephalitis, etc. All these scenarios, we specifically look for the BCG scar because in everything it means something different. Okay, so that is why looking at the BCG scar, it becomes very important. But more important is what if you don't see a scar? And these are the two scenarios that you need to keep in mind. Now, what are the adverse effects of the BCG vaccine? So it can lead to mild reactions like, abscess, injection site pain, reaction, lymphadenopathy, or delayed healing. But what we are more scared of are the dreadful severe complications like disseminated BCG infection and osteomyelitis. So what do I mean by BCG lymphadenitis? Now, this is again something that we commonly encounter in the OPD, where there is ipsilateral, axillary, supraclavicular, or lower cervical lymph node enlargement after getting the BCG vaccine. So when you have this kind of a scenario, what do you do? Do you need to give TB, anti-TB medications? Do you need to give antibiotics? Do you need to drain the abscess? What is it? So this again clinically becomes very important that when you have a child presenting to you with suspected BCG lymphadenitis, the first and most important will be to differentiate if it's suppurative versus non-suppurative, because the treatment for both is different. What do I mean by non-suppurative BCG lymphadenitis? Is usually the swelling is smaller, it's more firm, and often undergoes spontaneous resolution without any sequelae. So this is what a non-suppurative lymphadenitis looks like. Whereas on the other hand, if you have a suppurative lymphadenitis, there will be skin enlargement, progressive enlargement of the swelling with pain, erythema, fluctuation, softening, and skin changes. So this is typically what a suppurative and non-suppurative BCG lymphadenitis looks like. So what do you do in both the scenarios? If it's non-suppurative, then it's basically conservative management, follow-up, and ideally it should resolve on its own. But on the other hand, if it is suppurative, then it needs to be needle aspirated. If there is failure on repeated needle aspirations, then there is a need to undergo a surgical excision to remove that mass. Okay, so these are the two scenarios. And when you have a child presenting with suspected BCG lymphadenitis, first differentiate if it's suppurative and non-suppurative and accordingly follow the algorithm. What I really want to stress on over here is that there is no role of any antibiotics or any anti-TB drugs, either systemically or any oral instillation, to treat BCG lymphadenitis. So this was what used to be done before, that there was a school of thought of giving a certain regimen of the anti-TB drugs for the lymphadenitis, but that's no more the scenario. There is no need of antibiotics or anti-TB drugs for this. It has to be managed either conservatively or with needle aspiration and excision, depending on what the type of lymphadenitis is. Okay, so I hope this is clear. This is again important to remember and clinically very important actually when you have a child presenting with these symptoms. Now next, what do I mean when I say disseminated BCG infection? So for that, it has to have all these 3 points, which is a positive BCG culture showing the Mycobacterium bovis strain, which is used for the vaccine, or it could be a PCR, which is also showing the same organism. Along with that, you need to have an evidence of dissemination, which is a positive blood or bone marrow culture, and the infection at more than 2 sites other than the site of vaccination. So other than the local site, you can have involvement of the skin, other lymph nodes, liver, spleen, CNS, etc. Okay, that's point number 2. And third is systemic syndrome in the form of fever, weight loss, anemia, myalgia, etc., etc. So when you have all these 3 things present, is then when you say that this is suspected disseminated BCG. And what is important to remember is when you're suspecting a disseminated BCG infection, what you need to do is evaluate the child for underlying immunodeficiency states. Okay, because to have this kind of a florid infection, there has to be something going on with the immune system. Otherwise, BCG vaccine is given to so many kids across the country, but only a certain percentage of those actually develop this disseminated infection. So what is different in them that they are predisposed or they have developed this disseminated infection is what needs to be investigated. So common thing that have to be evaluated is presence of maybe HIV infection, SCID, which is severe combined immunodeficiency, chronic granulomatous disease, or look for susceptibility to mycobacterial diseases. Okay, so these are a few of the immunodeficiency states that need to be evaluated. I haven't really mentioned all of them. These are the commoner ones, but in general, the point to remember is that if you have a suspected disseminated BCG infection, then you should always evaluate for presence of immunodeficiency. Now, next, again, very important is what do you do with the vaccine in special situations? And the first one being in case of an HIV infected infant. Okay, so this is again important to remember. So if you have an infant who has been exposed to HIV, let's say the mother is HIV positive, but the infant is asymptomatic at birth, looking stable, then like any other child, you will give the BCG at birth. Okay, so what I want to stress on here is that the IAP recommendations are different from the WHO recommendations. So WHO says no BCG to HIV exposed, but the scenario in our country is different, looking at the endemicity of TB, looking at the population that has coexistent TB and HIV, etc. The IAP now recommends that if the child has been exposed to HIV but is asymptomatic at birth, then you will give BCG at birth like any other infant. Okay, that's point number one. Second, if for any reason the BCG was not given at birth and the infant has been tested or the neonate has been tested for HIV positive by early virology estimation, then BCG is delayed until ART started and the CD4 count is more than 25%. Okay, so to simplify this, let's say for whatsoever reason the child did not receive BCG at birth. Okay, and normally if you have a newborn who's born to a mother who's HIV positive, there are certain guidelines as to when you need to test if the baby is actually HIV positive or not. Okay, so a few of them say that you have to do that 4 to 8 weeks and then subsequent months. Sometimes the child might be tested for HIV right at birth. So in that scenario, if the child has not received, not received BCG at birth, or if the newborn is positive, is HIV positive by early, testing, then in that scenario, the BCG is delayed until ART started and the infant is stable, which is by definition CD4 count more than 25%. Okay, that's point number two. And third important thing is that for those children who are on ART and they haven't received BCG before, those kids can be given BCG vaccine once they're clinically well and stable. That means that the CD4 count is more than 25% in those less than 5 years, or a CD4 of more than 200 in more than 5 years of age, then you will give them a BCG vaccine. Okay, now what I want to stress here on is just to clear the confusion. I said catch-up immunization according to IEP is till 5 years of age. But here I'm saying that children who are on ART and haven't received the BCG, if they are well clinically stable, then and the CD4 is more than 200, you can give them BCG even if they're more than 5 years of age. So I hope there is no confusion, because this is a completely different scenario. This is particularly when you're talking about HIV positive kids. So, those guidelines of catch-up immunization according to IEP is for the general population. This is specifically with respect to HIV infected infants. I hope this is clear. If you have any questions, you can put them in the comment section below and I will do my best to solve it. Okay. So another important scenario is what do you do in preterm and low birth weight babies. So in them, you have to follow routine BCG vaccination as long as they're stable. Obviously, if the kids are really sick, they're ventilated, they're requiring inotropes, multiple supports, etc., you will not give. But if it's a stable, healthy preterm or low birth weight baby, you can give them BCG at birth. Okay. Now the last scenario is what do you do in neonates who are born to mothers who have pulmonary tuberculosis. So in this scenario also, you will give BCG at birth. And once you rule out TB in these infants or these newborns, asymptomatic newborns will be also given 6 months of isoniazid preventive therapy. So this is nothing to do with the BCG vaccine, but I just wanted to put in a point here that if the mother is, say, pulmonary tuberculosis positive, and you have, a baby who's born to this mother, you will give BCG at birth and you will investigate that baby if that baby has active tuberculosis. If not, so if you rule out active TB, then these asymptomatic newborns, other than receiving the BCG vaccine, will also get 6 months of isoniazid preventive treatment. Okay, I hope this thing is clear. There's always some amount of confusion as to what do you do with, these kids who are born to mothers who have pulmonary TB. You give them BCG or not? What do you do with HIV infected individuals? Do you give them? When do you give them? So that's why I wanted to spend some time discussing these three scenarios, which are clinically important, often cause confusion, and can be asked in your exams as well. So yeah, these were the three scenarios. Moving ahead, coming to the efficacy. So efficacy is about 45 to 99% almost for pulmonary tuberculosis. TB meningitis reduces by 73% and miliary TB incidence has reduced by 77% after getting the BCG vaccine. And it has been studied that those kids who are BCG vaccinated and are exposed to open pulmonary tuberculosis have a 19% lesser infection rate as compared to their unvaccinated counterparts. Okay, so this is about the efficacy. Now, last 1 or 2 points, contraindications. So if there has been anaphylaxis to any other component of the vaccine before, then that's a contraindication, which is true for any other vaccine as well. Other than that, if it's a symptomatic HIV or an immunocompromised HIV, then you do not give BCG. Kids on immunosuppressants or corticosteroids. So if you have immunosuppressants like your chemotherapy drugs or TNF alpha inhibitors, rituximab, infliximab, etc., then you do not give. Children with malignancy of the bone marrow or the lymphoid tissue also do not get BCG. And children who are born with congenital cellular immunodeficiency, particularly involving the interferon gamma pathway, are also contraindications to get a BCG vaccine. So these are a few that you should know. And just coming to one last concept of new TB vaccine. So there are several vaccines that are in phase 3 trials right now, which are being evaluated to replace or to act as an adjunct to the BCG vaccine. So there's VPM 1002, MTB VAC, M72, Immunovac, GAM-TB VAC, and BCG travel vaccine. Two of them that I want to specifically mention is the MTB vaccine, which is in phase 3 also being tried to be tested in infants, because most of these other vaccines have been tested in adults and a few also in adolescents, but the MTB vaccine in phase 3 is also being tested on infants, point number 1. And second, the M72/AS01E has been funded by the Bill and Melinda Gates Foundation, and that again is in the phase 3 trial. This vaccine is being used or is being tested in not only adults and adolescents, but also people with tuberculosis, people with HIV, people without HIV, and so it's involving a whole larger spectrum of population. So it's important to know that these are a few vaccines that are currently in phase 3, and if they pass the phase 3 trial and they prove the test of time, then probably they will also be out for the general population, and a lot of them will be helpful because of the wider population that it is targeting, and also it not only help in prevention of tuberculosis in the immunocompetent but also in the immunocompromised population. So this is one extra concept that I wanted to stress on, is the new TB vaccines, and this covers or this ends the discussion on the BCG vaccine. I hope you found it helpful. And if you have any questions, any doubts, or anything that I should emphasize on or clear, you can put it in the comment section, and I will answer those questions. So thank you so much for watching the video, and see you again soon with another video on another vaccine soon. Thank you.